I will start with the twin objectives of universal health coverage. The universal access to care when they want, where they want, how they want. So that's one aspect of it. How do we actually improve access to care? The second is, in accessing this care, they should not have financial hardship. I mean, we should not equate coverage to financial hardship. We may have 100% universal health insurance, but it may not eliminate financial hardship. So the beneficiary selection should be dictated by the financial hardship, not by a socio-economic strata. We are not actually monitoring in a survey and articulating our policy iterative changes with reference to what's happening to the financial hardship of all these beneficiaries. Because the hardship may be because we are only covering the hospital-based care, while the outpatient-based care is not covered. And most of the non-communicable diseases, it's outpatient care which costs more than the hospital-based care. So that is one policy thing as to what has to be covered. Who has to be covered, I think just now is discussed. One of the practical issue can be who is not eligible to be covered by tax-funded public health insurance. That means we have now, with the digitalization of economy, we have accurate information on financial position of each individual. So that means we can exclude a certain individuals based on their financial position. Second, certain employees are eligible to be covered by the employers. So that means they need not be covered by the public health insurance. The third is the ESI, which covers both employers as well as the government to protect these people. So one of the practical solutions to bring everybody under the coverage by exclusion. Assume that everybody is covered, but you exclude. Exclusion is much more easier than the inclusion. I think that's one, the second aspect of it, who has to be covered. The third is not only universal access to care, but access to care which is timely and decent quality, equitable, and delivered it with dignity. So these are not actually being looked at when we are targeting the USC measurements and indicators. Even the WHO indicators does not look at that. So a measurement has to be looked at that how are we assuring quality? Whether it's a public provider empaneled hospital or a private provider empaneled hospital, if we are not assuring quality, I mean, we are assuring quality of every product, every drug, every device, but we are not assuring quality of healthcare service. So why we are not mandating for every provider, whether it's a public health provider or private provider, that you are mandated to be accredited? You mandated to be say that we assure you quality, we assure you safety. So, I mean, we have to handhold some of the people, especially the small and the medium-sized hospitals, in transiting towards the quality accreditation, but we have to mandate that. The fourth, for the people to trust in the quality of care. I mean, today, the public healthcare system provides you free care. But why still they are seeking private health care? Because they don't trust the quality. Now they have another dilemma. They are going to private health care. Now they are not trusting the ethics of private care. Is it an appropriate care? Is it an appropriate indication? So they're in a dilemma. I think the government has the onus to have that oversight on the quality assurance by each of the provider. The oversight comes from both ways. One is through monitoring the outcomes. For monitoring the outcomes, again, another second mandate that every provider has to adopt interoperable, standards-based health information system. Without that, we cannot monitor the outcomes. So these are the, I think, 4 or 5 policy suggestions based on what worked in different systems, different countries and different systems. And I'm sure, especially since we have the 3 pillars, the digital pillar, the coverage pillar, and the healthcare pillar, if these 3 are synergized and they work in a collaborative and coordinated fashion, it can be achieved.